Good afternoon, and welcome to our national webinar in recognition of National Public Health Week, Ready, Set, Action, Bridging Public Health and Policy in a Shifting Landscape, hosted by Trust for America's Health, commonly known as TFAH. My name is Tim Hughes, the External Relations and Outreach Manager at TFAH. We would like to thank our speakers and audience for being here with us today. Real-time captioning is being provided by Nicole of AI Media. For captions, click on More at the bottom right of your screen with the three dots. Next, click on Close Caption. For ASL interpreting, provided by Daisy and Becky with Keystone Interpreting, click Interpretations at the bottom of your screen and select American Sign Language. We encourage you all to share your thoughts and questions about today's presentation by typing them in the Q&A box. We'll try to answer as many as we can as time permits. To open the Q&A box, click the Q&A icon at the bottom of your screen. From there, select Enter when you are ready to submit your question. And now it is my pleasure to introduce the moderator of this event, Dr. Takesha Dwan-Everett, TFAH's Executive Vice President. In this role, she works in partnerships with TFAH's President and CEO to chart and implement the organization's strategic direction and priorities, provides counsel on current and emerging policy issues, and engages with key organizations, policymakers, and other partners to advance policy priorities to improve the public's health and promote equity. Welcome, Dr. Everett.
Thank you, Tim, and thank you to everyone for joining us today for this important discussion. As mentioned, I'm Dr. Takesha Dwan-Everett, the Executive Vice President at Trust for America's Health, and I'd like to welcome you all and thank our esteemed panelists for taking the time to attend this event today. We are honored that you are all here. Our agenda for today is on this slide. After the discussion, our panelists will have time for your questions that are coming from the audience. TFAH is proud to be celebrating our 25th year, and as a part of that, we are kicking off a series of webinars this year that will focus on where public health currently is and where we are heading. Specifically, it's important for all of us to weigh how the field has been doing and how we can evolve, especially in this rapidly changing time. We will continue to highlight throughout the year the recent past, thinking about how the public health system has worked and how it's supported communities prior and soon after federal changes, the present, including navigating the initial wake of those policy decisions and how they affect communities, and thinking forward to the future, reflecting on how our field of practice can learn from these experiences to enhance how we support prevention. This is a part of what we're thinking about over the course of this year, but it's also the framework for what we're discussing today. My hope for our webinar today is that you will all leave with a better understanding of how public health systems are navigating this evolving landscape as we examine the status of key federal agencies and the broader network of public health programs. As a reminder, we will have time for your questions at the end, and we want to ensure that we get to all of your questions. So please be sure to use the Q&A box, not the chat, and that's where we will look for all of your questions after we go through our panelist presentations. I'm now pleased to welcome our amazing panel. First, I'd like to introduce Darlene Wong-Briggs, who is the Deputy Director of Special Projects at the Network for Public Health Law, where she leads trust building and research efforts to bring traditional and non-traditional partners together to modernize systems. She joined the Network for Public Health Law in 2023, where she's been working to translate her over 15 years of commercial tobacco control policy experience to broader public health systems improvement work. This experience was gained at a local Colorado Health Department, the FDA, Campaign for Tobacco-Free Kids, the O'Neill Institute for National Global Health Law at Georgetown University Law Center, and the Public Health Law Center at Mitchell Hamlin School of Law. I'm also pleased to have with us today Dr. Simbo Ige, the Commissioner of the Chicago Department of Public Health. Dr. Ige's public health career spans nearly 2 decades, and prior to her current role, she served as the Managing Director of Programs at the Robert Wood Johnson Foundation. Dr. Ige oversaw partnerships with health organizations nationwide, working together, making public health and healthcare systems accountable and equitable. Really important work. But continuing that important work, she's dealing with everyday challenges and opportunities of addressing public health at the Chicago Department of Public Health. An experience that she's extending her experience previously as the Assistant Commissioner of the New York City Department of Public Health and Mental Hygiene, where she provided oversight to a range of programs, including the city's pandemic response, food security programs, housing and health initiatives, mental health programs, violence prevention, and the Public Health Core Initiative. Last but certainly not least, we are so excited to have Scott Thorpe joining us today. He's the executive director and founder of the Southern Alliance for Public Health Leadership, which partners with state and local public health efforts in the southeastern US on strategies and advocacy for immunizations, access to care, and infant and maternal mortality. Scott has held senior leadership roles with the Georgia Department of Public Health, Partners in Health, and the South Carolina Department of Health and Environmental Control. He's an expert in public health infrastructure, having directed major COVID-19 response teams, managed local health departments, and spearheaded health equity initiatives centered on community health workers and electronic health record modernization. Darlene, Dr. Ige, and Scott, I'm so thankful that you are joining us here today, and I am so excited to get us into our discussion. To guide our questions, we have a few things, we have a few, to guide our discussion, we have a few questions to reflect on the past year, what's happening right now in the present, and thinking a little bit ahead to the future of public health. So I want to start this conversation with what's happened over the past year. And I'm going to direct the question first to Darlene, then ask Dr. Ige to answer, and then move to Scott. So, reflecting over the past year, I want to hear from you what federal administrative or policy decision had the greatest effect on your community and or the type of work that you're currently doing.
Sure.
And
Thanks, Dr. Everett, and thanks, Brianka and the rest of the TFAH team for having me here today. I'm with the Network for Public Health Law. To just get straight to your question, Dr. Everett, President Trump issued a record-setting 200 plus executive orders, or EOs, right, in 2025, and over half were handed down in the first 100 days of his administration. And almost immediately, we and our public health law partners were being asked what various anti-DEI, DEIA, and immigration-related EOs and other federal actions meant for public-facing materials, and an array of public health services, programs, and their funding. So I would use that big, broad category of anti-DEI, DEIA, and immigration-related issues. DEI, diversity, equity, inclusion, of course. DEIA, diversity, equity, inclusion, accessibility. Based on those core constitutional tenets, including the document's opening affirmation of a democracy established by and for, quote, we the people, end quote, as well as separation of powers among the three branches of government, a limited federal government, federalism or shared power between the federal and state governments, and fundamental rights such as free speech, due process, and equal protection. We and our partners reminded folks that there are limits to federal executive orders and an array of various other sources of law, including grants and contracts, statutes and regulations, the laws of other jurisdictions, state and local, tribal, territorial, and court decisions that also shape the impact of any particular directive at a particular point in time. I think the last thing I'll just say is that what was clear from the actions of the current administration, right, was, and it's still clear, quite frankly, to this day, the intent is to strong arm people to comply with their views of how the world should exist, including a narrower type of a public health field and work that we all do, as well as the false and harmful ideal that there are less deserving people that then translates into policies where health improvements continue to be unevenly distributed, with those experiencing the greatest health inequities bearing the brunt of that burden. I've stayed at a high level. I will also say that the network recently released Executive Order Watch, which collects in one place many of the 2025 federal EOs that impacted both the work of public health as a field and, of course, the public health too. We did a webinar just 2 weeks ago to introduce that resource to the field. It includes 69 EOs that have largely harmed public health, both in the traditional sense and through a broader health and all policy lens. That webinar couldn't cover all EO topics, but our team focused on equity, public health more generally, immigration, and voting rights. So I can share that link in the chat here for folks to access that if they want some more details.
Amazing. Thank you. There's no real way to summarize everything that you said, but I will say the through point of what I hear is you are hyperactivated from the legal standpoint as a network to really go into action to help people understand as we were navigating the complex nature of a record-breaking number of executive orders coming out that was affecting the field writ large. And so it sounds like a lot of energy and effort to really understand and help others understand the force of what actual, rather than perceived, force of law or lack of the orders have, and what that actually means for each individual actor in the field. Dr. Ige, how has your work been impacted? How has your community, the things that you're seeing in Chicago, been impacted by federal administrative or policy decisions over the last year?
Well, thank you very much. To set the context, I am a commissioner of a big city, the third largest city in the country, more than 10 million people in Metro Chicago, 50, 60 million tourists every year. So it is a big deal. Now, let's zoom out a little. Public health, by definition, is about the public. So the reason public health is a little different from medicine is that medicine is about individuals. Public health is about communities and population groups. And in looking at the impact, when you think about 69 executive orders, it is the collective impact of the policy orientation and how all of that has impacted who we serve and what we're able to provide. So the who, immigrant communities, people experiencing homelessness, people with substance use disorders, LGBTQ community, people of color, all of the policy changes and attempts to roll back funding have been tailored at limiting who we can serve and what we can provide. So this shift has touched coverage, who gets insurance coverage. It has touched access, who can have certain services. It has impacted trust because now folks don't believe that government is looking out for them. It has touched equity. These were all the lessons we learned the hard way during COVID when the United States was impacted more than other developed countries, where our outcomes and the life expectancy impact was worse than peer countries. And now we have been stifled. We are being constrained in terms of who we can serve and how resources can be deployed to serve our communities. So it is frightening that the lessons that we learned over COVID and how come we emerged from the pandemic so battered and bruised, that we're in a situation where the policies and laws are even worse than that period. I'll give an example of what that means. During COVID, we saw that communities that are under-resourced, underserved are the most impacted. And since COVID, we have seen outbreaks of measles and outbreaks of mpox and outbreaks of meningococcal disease across the country. Normally, the way we will respond to that is which communities are most impacted. But for mpox, If federal funds are not available to support LGBTQ communities or communities of color, and we cannot tailor the funding that way, then how do we respond to communities that are most impacted, which means diseases are simmering, and we have to then stretch local resources that are already not sufficient. Big city, 10 million people, tourists all over the world coming here. This is what federal government is designed to do. And this has now been left to local municipalities to solve for on their own. Not effective, not equitable, not accessible.
You all make it so hard to moderate the panel because I just want to go and dive in deeper into each one of the responses you have. But what I really am taking away from your response is thinking through the fact that the third largest city in the United States, and what's really fascinating in terms of how our country is set up is we do not have borders really, right? Our borders, though we have states and cities and towns, are artificial. And when you think of that, the importance of having strong federal support at the local level to attend to the infrastructure necessary and needed to provide the coverage, access, and attune to the population's health in a large city that does have a huge influx of visitors, as well as residents who are permanent, has been really harmed in the last year. And you've really been impacted by that. We'll dig a little bit into that a little bit more, but I'm going to transition to Scott and say, Scott, what are you seeing in the Southeast? What has happened for you? What's been the most important or impactful administrative or federal policy decision that's impacted the work you're doing in the Southeast?
Yeah. So thank you for having me here today. I think for us, the shifts in vaccine policy at the federal level have more than anything else created a lot of chaos at a state and local level around how to respond. We have a system that's really built on the idea that like everybody generally agrees that vaccines are a good thing and that everyone who wants to get vaccinated should have easy access to it. And when one part of that system suddenly starts to break down and disagree and generate policies that conflict with everybody else, it sort of sows chaos in the system. So a good example is some of the changes around the COVID vaccine have sort of downstream impacts on how state and local health departments and other vaccine providers can readily access the vaccine and who can provide it. And it just kind of left a lot of state and local public health in the South kind of twisting in the wind, trying to figure out what the policy is on any given day. And for consumers trying to navigate these kind of situations, that's nearly impossible. And so trying to understand if you are just a normal person interacting with our public health or healthcare system, like what is recommended on any given day. Right now, the answer is, well, it depends on what's going on with any given federal lawsuit. And that's not really good for public health. And so that those vaccine policy shifts, of which there have been more than we can probably all count, has really made it hard for the work that we do and the work that state and local public health do, all in the midst of massive measles outbreaks, when we really need to be reaching as many people with vaccines and education around vaccines as possible.
Yes, Scott, and what I hear from you is the tumultuous nature of what's happening with vaccine policy is really having us move from a space where we're really relying on the evidence and science in terms of how vaccines help our collective manage our health and the impact of that, to one in which I'm going to use this all the time. Any given lawsuit, like where are we in the process of any given lawsuit at any given time, which is not an effective way to promote public health and to actually advance health and safety among the population. I'm going to shift to one more question around the present, because one of the things I think we want to highlight today is the impact that federal action is having on state and local, but also how advocacy can help in the context of what's going on. So we have seen some effective advocacy actually help to stall or pause or eliminate some of the detrimental administrative actions or decisions that we've seen. One example I can think of is thinking about congressional funding and ensuring that what Congress is supporting in terms of funding in public health and healthcare programs are actually still going on. I'd love to hear from each of you. How has advocacy played a role in your work over the last year? And think of this federal, state, local, whatever example comes to your mind around effective advocacy and its impact it has had in the work that you do. And I'll start with Darlene.
Sure. So, I mean, you've both already touched on it, advocacy through the courts, both public health specific advocacy and then advocacy by social justice, civil rights, and data privacy advocates as well has been instrumental in stalling a complete destruction of public health. All of the public health lawsuits to protect federal public health staff, try to protect public health staff, right? All of their lawsuits around research grant cuts, and the clawback of public health infrastructure grant funds. Maybe Scott will talk about the vaccine win. That was huge, right? We know we're not out of the woods yet, but the AAP decision is a big one. American Academy for Pediatrics, sort of undoing most of what the federal administration has done related to the advisory committee for immunizations. And I think, one thing I will note is I think it was in January, Democracy Forward, one of the organizations that's been bringing a lot of the lawsuits, they noted that the current administration is actually largely losing in court. Their loss rate fluctuates at any given time, but it's generally between 70 to 80%. And so the courts really have served as an important backstop to protecting public health. Not necessarily entirely rolling back things yet. That's going to take some time. And obviously, we're going to be reeling from this experience for the next decade, maybe even longer. But the courts have been important. I will also say that I have been really excited to see a much needed and renewed effort to prioritize legislative and regulatory advocacy in the executive branch among the public health field as well. It's great to have a better balance of efforts across the three different policymaking branches of government. And I feel like our field has seen the light that advocacy is so important and a part of everybody's jobs, knowing there are, legal constraints for certain government employees and others as well. But I think there's a real sense of we're all in this together and advocacy has to be part of everybody's job.
Love that. Thank you, Dr. Ige.
Yes, I will give the example of HIV. So CDPH, as a big city, gets about $40 million across from federal funding for different HIV-related, from CDC and HRSA and HUD for HIV-related work. We support 10 counties, that's City of Chicago and the color counties. And we have about 20,000 people living with HIV that depend on this funding for housing and for, wraparound services, including HIV treatment. So there has been several attempts to claw back that funding and advocacy efforts, HIV organizations, people living with HIV, elected official, congressional leaders, everybody coming together. I had an op-ed in the news with the director of the state and the county, us, everybody elevating how important it is that 40 years of progress not be jeopardized. For every HIV case that we prevent, it's about $40,000 in lifetime expenses, healthcare expenses. So these are some wins that we are very happy about. You may also know that Chicago was one of 4 cities that's part of 4 states that were targeted in an attempt to claw back the public health infrastructure grant. Again, this is about, over $20 million in funding that support critical infrastructure and data and staffing and disease response activities and mobile services, etc. Again, large city, many different opportunities to support our communities in Chicago. And these four states were targeted for clawing back. That became a legal battle. And we're very pleased that we got a temporary restraining order and temporary injunction. So this has been the cycle. I think the state of Illinois has more than maybe 30 different lawsuits because literally every day, every week, there is a new attempt to club our public health protections, etc. And I will just share why these things are important. In Chicago, life expectancy uh, for people of color was trailing behind other cities. We've been doing a lot of work, and steadily that has been increasing to a point where we have begun to close the racial life expectancy gaps. These are some of the reasons why we need to protect the work that we're doing, showing that when we invest in communities, when we invest in an equitable, culturally competent way, we can change some of these outcomes for HIV, for mpox, for opioid overdoses, for violence reduction. Opioid overdoses in Chicago were reduced by 37% in 1 year. Violence reduced by 22%, mortality related to these things. This is what public health does. This is why we need to protect this infrastructure. But we're spending all of that time now writing letters, making noise, saying, let us protect the good work that we have started. These are some of the real-time impacts in a big city like ours.
Thank you. Okay, Scott, bring us in. What's happening for you?
Yeah, a lot of our advocacy focuses in our state legislatures, most of which are well on their way to wrapping up their sessions for this year, which I'm very thankful for. But I think a lot of times when we talk about state and local government, they honestly get overlooked. And there's a lot of policy action that has a lot of impact on what's going on. And frankly, we spend a lot of time just sharing data and educating lawmakers with what these issues look like in their communities. I cannot tell you how many legislators I've talked to on both sides of the aisle who will say all of the people who live in my community are vaccinated. And I can share the data to show that that's definitely not true. And so I think just helping them understand what the risks are of negative changes to vaccine requirements for schools or for daycares, doing things that limit access to care in various ways, doing things that hinder healthcare in rural communities or pull back support from rural communities. Those are all things that have a real, tangible, calculatable impact. And I don't think especially for these state and local folks, they hear from advocates enough. And so we spend a lot of time facilitating that and doing more to connect them to folks who work in public health who are seeing this stuff day to day. It's obviously really tangible in a state like South Carolina where we work, where we have this really large measles outbreak. But I always like to remind people that if you look at the vaccination rate for Spartanburg County as a whole for the MMR, it's actually pretty normal for the Southeast, very much not an outlier. And so we're lucky we haven't seen more of that yet. And that's something we really try to emphasize as we're talking to legislators about some of the bills that are popping up right now.
Thank you. Thank you, each of you, for your responses there. I hear a very common thread between what you're saying, and it's whether we're thinking about advocacy from a legal advocacy perspective, federal legislative one, or a state and local legislative one. The key notion is if we're not speaking up about what's happening and providing the data and information to those who are able to make policy decisions, because policy is an intervention in public health, then we're risking the continuation of negative and poor outcomes. And not just for certain populations. We definitely know from an equity lens, there are certain populations who are facing inequities, structural inequities related to some of the healthcare outcomes we're looking for. But I want to go back to the word that each of you keep saying each time you answer the question, the collective. Like if we're not actually doing things well for the collective, this isn't an individual problem, it's a population problem. Thank you so much for your reflections over the past year. I want to move us much more into proximal times. Let's look at 2026 and what's going on for us right now. What resources are needed to ensure that the public health challenges you all are looking at, whether it's from a legal perspective or local public health or vaccines, what's needed to ensure that the public health challenges we are facing can be addressed in the communities you reach? And I'm going to start this time with Dr. Ige, go to Scott, and then go to Darlene.
I will give you a couple examples. Public health, we're interested in people living long, healthy lives. So if we start with what is it that is leading to premature mortality in our communities that we can do something about, I will start with chronic diseases, especially heart-related diseases. In the city of Chicago, mortality from chronic diseases is the number one reason why people don't live to the age of 65. Heart disease, and all part of that is access to healthy food and nutrition. Part of that is access to exercise opportunity and the physical infrastructure that's available in communities. Part of that is the predatory marketing of tobacco industry and menthol tobacco, etc. Every single one of these have been targeted, like tobacco, work, food, access. And so what we are saying is that increasingly the workforce of the United States continues to be at risk of developing chronic diseases. So the burden on the healthcare system continues to increase, and the economic impact of that continues to be felt. We are spending more on healthcare than any other country because we refuse to invest in preventative measures and the safety net that help people who are struggling to access the protective factors that they need to stay healthy. We are unraveling. And these are real-time impacts. So that is mortality. Now, what keeps people going to the hospital and taking away resources from even more severe illnesses? I'll give an example. In Chicago alone, in 1 year, 21,000 hospitalization for mental health related admissions. Many of these admissions are repeated admissions. Which means if your emergency department beds are occupied by people with mental illnesses, then those who have cancer and those who have other diseases, then you don't have space to accommodate those people and serve them. And many of these issues are driven by economic pressures and other uncertainties in communities and lack of resources. So you've seen attempts, to unravel mental health services, to unravel substance use disorder services, etc. So these are real. For us, we are in the front line. We deal with this every day. And we see the impact on the healthcare system. We see the impact on organizations and people wanting their staff to be productive and contribute to the economy. We see the impact of this on our schools. So public health is really tangible. I'll give a last example. Again, Chicago, as a big city, we have 17,000 food establishments. Imagine how many people you need to inspect those food establishments to prevent outbreaks of diseases. Now, if there's an outbreak of disease in Chicago, the tourist industry, the hospitality industry, all of those folks who are dependent on the successful Lollapalooza and NASCAR and, Taste of Chicago event where millions of people come in, all of them will be negatively impacted. If we don't have the disease investigation specialists and the epidemiologists and the public health inspectors who ensure that this infrastructure is available and Chicago is safe, it has consequences for everybody, including even the airport and all of those who depend on businesses that's related to tourism. So it is not just that we are giving vaccines, is that the very fabric of most economies, most cities, most municipalities, most civilization depends on having a protective infrastructure that enables people to live, work, and play in healthy environments. And that is what we do every day. So how do we make that visible? How do we make policymakers appreciate that and why it is important that our laws, our funding, our resources continue to protect that so that we can all thrive? So I think that's the task for us in 2026. How do we make our work relatable, visible, so that everybody understand that it is necessary for all of our collective, uh, lives?
Thank you, Scott.
Yeah, I think this feels particularly present in the South, across a swath of states where we haven't expanded Medicaid.
Mhm.
But access to care is front and in particular rural access to care needs more money. It is the number of hospitals we see closing, the number of labor and delivery units we see closing, the number of primary care providers who are retiring. I it's not going to get better anytime soon, and it needs more money across all of these states, and that drives a lot of what we expect to be focused on this year, both in terms of what's happening with the rural health transformation funds in all the states that we work in. But there is also room for policy change within the agencies in all these states too. We have these sort of instances of administrative friction that we see with, for example, people struggling to enroll and stay on the Medicaid program. Um, and that's insurance and eventually payment for all of these healthcare providers who are struggling. And so there are, I also think, opportunities for us to work on sort of agency level improvements that don't necessarily need uh, uh, a bill to run through a state legislature. But the access um, is priority number one across so many areas in the South right now, as we see healthcare infrastructure just on the verge of collapse in a lot of places.
Okay, thank you, Darlene.
So maybe not to repeat what's already been said, but thinking about resources that help get us to what you've all talked about, right? To get the more funding and community impact, community power needs to be built. That's what changes who's in office, right? And our ability to flex that advocacy skill and build better advocacy coalitions. Cross-sector partnerships, obviously, with the reduction in funding, we're all going to have to be more uh, cognizant of needing to work together and use limited resources more efficiently and more coordinated. Getting to some of that administrative friction and figuring out how to do that work better. And I think at the center of all of that really is trust and how that resource is either built up or depleted based on how we interact with people, quite frankly, right? I think about the golden rule of, I've brought up with treat others how I would like to be treated, but I also think there's a really important piece of treating others how they want to be treated, which kind of requires people to pause and think about, right? What are other people's needs and preferences, and what am I doing that furthers that or diminishes that? Those basic types of interactions really do impact the levels of trust and ability to build community power and do the advocacy that we need and to be efficient in delivering our services and effective, right? That then allows us to have the advocacy wins that we're looking for.
That's awesome. So a few things that I'm hearing from you all. You've mentioned kind of access is key. You've mentioned partnerships are important. You've mentioned the notion that trust is important. So I'm going to pull a couple of themes, and we're going to pull on some of those themes and ask you, first and foremost, how are you engaging community partners and or groups in your work that you're doing now? And particularly thinking about community partners or groups from a different sector, from a non-traditional public health sector, to actually advance the public's health. And I'll start with Scott on this question, and then I'll go to Darlene and then go to Dr. Ige.
Yeah, I mean, I think for us, we rely really heavily on local engagement around public health issues to drive how we approach either sort of traditional public health coordination work or advocacy work. Because I think when we talk about, say, I don't know, statewide vaccination rates or countywide vaccination rates, on its face, I don't think that data is actually all that useful to legislators. But what I do think matters is when you can provide texture and a story that goes along with that data and really describe with your community partners what's happening. And a good example of that is we do some work in DeKalb County, Georgia, which for folks who don't know is also where the CDC is headquartered. And there are particularly low vaccination rates in South DeKalb in sort of the South side. And if you sort of dig into what's going on there and you start talking to community partners, this isn't a political valence. This isn't being driven by the current political moment. It's actually being driven by a serious access issue. Families are struggling to find access to care. They're struggling to find pediatricians to see their kids. All of the social drivers that keep people from accessing our healthcare system are very much present there. Issues around housing, issues around transportation, issues around anything, you name it. And we 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 work with community partners to understand what's really going on there so that we can be better at our jobs and be better informed when we're explaining the situation to legislators. Because that situation in South Cab isn't about religious exemptions. It's not about what's happening politically around vaccines. It's a completely separate issue and requires a completely separate solution. And so we have to keep those community partners really centered in our work, because they know better than we do, almost always, what's happening at a really hyper local level. And so that drives a lot of how we even talk about this stuff.
God, I could continue our conversation for an entire hour just on the on your response, but I know I don't have that time. But I really want to lift up and applaud the point you made that what is proximal and important to community members isn't tied to a specific administration, a specific moment, a specific now, that there are some systemic and historic issues that they have been lifting up and have seen. And that our job in public health is to collectively work with them to build that narrative and to find the response to those issues in tumultuous times, but also in calm and kind of what we would
Hmm.
call steady times. Sorry, Darlene, that I had to pop in there and say that, but Darlene, up to you now.
No, that was great because I mean, I just want to riff on that, right? It is um, engaging with people who use public health services. That's all of us, right? And for different types of resources and issue areas, right? We have a harm reduction team who serves individuals, people who use drugs, organizations who are serving people who use drugs, institutions that support people who use drugs, right? We are engaging with all of those folks and taking all of the lessons and conversations and lenses and threads we're hearing from them and putting them into our resources. They are forming the types of resources we deliver to the field and to users of public health services. I think one of the newer areas that we're really excited about is to work with more groups who are serving immigrant populations and families, mixed status families as well, trying to understand what concerns they have and how resources that we might create that are geared towards that particular audience are helpful to them as well as the public health field and for advocacy purposes as well.
Great. And Dr. Ige, before I turn to you for your answer to this question, I do want to remind our participants who are in the audience that your questions are, we're looking forward to hearing and seeing your questions. You can offer your questions in the Q&A chat, in the Q&A box, not the chat box. If you're having difficulty finding that, just hit the three dots to the lower right of your screen. You'll see Q&A there and provide your questions. I could selfishly take all the time and ask all of my questions, but we really do want to make sure we're making this useful and impactful to the work that you do. So Dr. Ige, let's hear from you. How are you using and using and involving and engaging community partners and groups in the work that you're doing in Chicago?
Thank you. We're using an all of community approach, especially the voices of those who, beyond those who have lived experiences. So it is important to elevate the voices of those with lived experience and say, this is my impact. But we're at a time where we are in a zero-sum mindset where people feel like if I give you resources, you're taking something away from me. So engaging those who feel like something will be taken away from them if health coverage increases, for instance, and making it visible and getting their voices and buy-in and demonstrating how this is collective um, impact, that having services for those who need it the most also makes it easier for you to access the services that you need. If emergency departments are overrun by measles, then your waiting time and all of the other services that you need will be harder. And so when we have that collective outcry, it is more impactful. And those are some of the strategies that we're, elevating. This is not just a problem of communities of color. This is an all of Chicago problem. And when we are trying to engage elected officials, again, it's not just those who are blue. It's like, how do we elevate these issues to across party lines so that people see that it is, everybody benefits from this. So community organizations across board, faith-based organizations across board, bringing in other sectors. Sometimes we're talking about public health without involving healthcare, or even the education sector, and even the health and human services sector, because housing for us in big cities, people experiencing homelessness are a priority population for us, and that is the health and human services sector writ large. So just broadening the coalition to more than just health-based and broadening the voices to include those who have misgivings or who are concerned that something will be taken away from them by supporting other communities are some of the strategies that we're using to elevate the need for investment in public health.
Love that. Thank you. Well, before I ask my final kind of frontier question about the future, I'm going to turn to Dr. Brianka Merritt, who's our Director of Policy, to see if we have any questions in the Q&A we should lift up to the panelists.
Yes, thank you, Dr. Everett, and thank you again to all of our wonderful panelists for your participation and interesting insights about the past year. So one question that we have is kind of a bit of a future-facing question about, let's say we do have a new administration that wants to restore some of the programs and efforts that have been lost, and they're wondering how long it might take to recover some of those programs or functions that are gone. I know that that might be a very analytic question. So if you can't answer it in a numerical way, maybe alternatively, if you could give an example of maybe a function in your work that has been lost and maybe what it might take to restore that in future.
I can start because we're just doing that exercise. So I did mention that we've been working on improving life expectancy in Chicago, and that work started in 2010. And we saw that the life expectancy gap among Black Chicagoans and the rest of the country continued to widen over time, from 9.4 years to 12.7 years before the pandemic. But if we start to look at it from the pandemic and the impact that the pandemic had on premature mortality, it has taken, this is 2026, it has taken us 6 years to regain, to get back to pre-pandemic levels. 6 years of hard work trying to gain the lost ground during the pandemic. The pandemic not just impacted COVID-related outcomes, it impacted prenatal care. We started as a result of the pandemic to see congenital syphilis to 500 times increase in congenital syphilis because people were missing prenatal care because there was interruption in care there. It is 5 years now of trying to correct that. We're down by 50%, but there's still work to do. We saw a doubling of sexually transmitted infections because people's access to PEP and PrEP was interrupted, and gaining the lost grounds and regaining all of that and getting people back connected to care. It's taken 5 years and we're still not where we were pre-pandemic. Chronic disease and engagement in care and annual medical examinations, a number of people showing up for their appointment. These are the real-time impacts when we interrupt care. So we roll back Medicaid, we roll back healthcare insurance. We start to see all kinds of things pop up in emergency room that are ambulatory care sensitive conditions. This could have been handled at the primary care level if people had health insurance, but now they're showing up in emergency department. It takes at least 5 years to correct those things. So it is not just that we have an administration and this is a temporary thing, it's that the impact of these policies and these actions are far-reaching and takes a long time to correct. I'll give one last example of when we impact vaccination coverage and we have measles outbreak. We had a measles outbreak in Chicago in 2024. It was 54 cases. The estimate of the cost of time and that was necessary to address that was about $8 million for about a 3-month period. For every day that we were not able to mount a vaccination campaign, it will have increased the duration of that outbreak by a couple of weeks for every day of delay. So when we stifle vaccination and we cause confusion and people, it is not that people who were willing to get vaccinated before now say they're not going to get vaccinated. What happens is that they wait. They say, I am going to wait and see what happens. And that waiting builds a pool of susceptible people. And the impact of that is not just monetary, it is in staff time, and it is the lost economic impact, especially in schools and the time lost there. So these are not trivial things. These have real-time impact, not just in lives impacted, in monetary terms, and the time it takes to correct these things. The expertise that have been lost at CDC, the expertise that have been lost at NIH, it takes years to regain the lost ground. So we need everybody working together to address these things and advocate and elevate for policies that keep our country and our cities safe.
I have what I think is a fairly short and sweet answer to this, which is I really firmly believe that health departments deserve a lot more unrestricted funds. I think public health has a little bit of a sort of poverty mindset around how we approach a lot of the problems that we have, which is how are we going to sort of cobble together the resources to solve whatever issues we have? And that's not always particularly effective, sometimes counterproductive. And it's because we have all of these giant block grants that we're dependent on to make public health work. And if health departments had more flexibility to respond to the actual local needs that they have, I think it would make a lot of this a lot easier.
Well, Scott, you alluded to this in answer to this next question that we have, but we're going to wrap up with this one. And this is one about lessons learned from the recent public health challenges you've all discussed. And if you could share a little bit more about anything adding to what you said, Scott, about where existing policy fell short and maybe how local jurisdictions could use that experience and lessons learned to build more resilient programs that can withstand future shifts.
Yeah, I mean, I think one of the important things for us all to remember is that like the issues around funding for public health didn't start just in this administration. And certainly predated, at least in the states that we work in the South. Really, most of our states saw huge cuts during the Great Recession in the mid to late 2000s and never got those funds back. And so I think restoring that funding and that support has to be part of our path forward for effective public health in the future. And that doesn't just come from the federal government. That's something we can advocate for to state governments. Your county governments are also likely putting funding into, even in systems that are centralized, or putting funding into your local health departments. They can put more. And frankly, county commissioners or county councilors probably haven't heard much from folks about how much money they're putting into public health. So it's certainly something to start pestering them about.
Thank you, Scott. I'm going to ask Darlene, do you have one final word you want to add to the conversation before I close us out? Because we asked two questions, and I think you might have something that you want to say on one or the other.
It's actually just building on this point of de-siloing the funding and thus the work, right? Governmental public health in particular really is piecing together a lot of different things and is really restricted on delivering in certain areas. And there was so much progress made from the COVID funds and public health infrastructure grant funds, right? And still being made with those funds. There's also frameworks, right, that the public health system adheres to: 10 essential public health services, foundational public health services for governmental public health. Those are really great frameworks, right, to help folks prioritize what types of infrastructure and services need to be funded to help demonstrate a particular use for unrestricted funds too, right? And I think there's really great examples from states that have been working very intentionally over the last decade plus, right, to shift the way their public health system is funded from largely federal to state and county funds. And I think we can really learn from what all of those states are doing and how they're measuring how much funding a state public health system actually needs, and then demonstrating progress over years or stalled progress that helps decision makers just understand the impact of their decisions.
Well, thank you so much, Darlene and Dr. Ige and Scott, for being an amazing panel today. Thank you to all of our attendees for your questions. I know we stated that our process over the course of this year, as well as what we're doing today on this webinar, is thinking about the past, its impact on the present, and thinking about our future ahead. And when I listen to all of the panelists today, what I hear about the future of public health is that we need to be able to have a more resilient, durable public health system that is responsive to the needs of the people, working in conjunction with the community to create the changes and opportunities that we want to see for our collective health, and making sure that advocacy, diverse and necessary and unrestricted funding, and enough funding and infrastructure support is what the public health field needs in order to rebuild and continue to build trust with the community and to serve it in its best capacity. I want to appreciate and thank you all for the work that you do every day. It's difficult, tough, and enduring work, but I hope that you get all of the support that you need from people in your community and that you look to us as TIFA as a partner for your work. As we're nearing the end of our panel today, I want to thank our panelists again, thank AI Media Caption Service, Keystone Interpreting, and our behind-the-scenes TIFA staff, and each of you who participated today. We clearly didn't have enough time. We could have gone on for hours and hours and hours, but we hope that you found this informative and impactful in understanding how the federal changes that are happening actually have real impact at the state and local level, and of course, in our everyday legal advocacy and system. Please join us as we continue these conversations in our next webinar happening on May 12th at 2 p.m. entitled Building Bridges, Not Barriers, Advancing Health Equity in a Shifting Landscape. Thank you again. When this concludes, we will have the recording available on tifa.org as well as our slides. Thanks again for joining us and have an amazing rest of your day and week ahead.